Being this late after lunch, my two goals for this talk are to be timely and to be energetic. So I'm going to do my very best with both of those. So my topic that I'm going to be discussing today is clinical trials in the ultra-rare leukodystrophies. So I'm not focusing specifically on one trial, although I will be giving some of this in the context of Canavan disease, but more broadly going to be talking about different issues that you want to be considering when you're thinking about how to move towards trial readiness in different disorders and what designing a trial might look like. Okay, so my disclosures, I am an investigator on multiple gene therapy trials and ASO trials at MGH, and I receive funding from a couple of sources. So as the last talk, I thought it would be best to start by defining leukodystrophies. So leukodystrophies, as we all know here, we're talking about a rare group of neurogenetic disorders that are affecting the white matter in the central nervous system, right? So we're thinking about myelin, we're thinking about the ability to send signals through the brain and spinal cord. We've talked about a number of leukodystrophies over the past 2 days, but really there's a large number of disorders that we haven't touched upon. And there are still many more disorders that exist and we have not yet classified. This is important to think about because we group them together as a common set of disorders, the leukodystrophies, and there are some common clinical features, but really this is a very clinically heterogeneous group. So we've talked about different disorders that start early in life with infantile onset, disorders that start later in life in adulthood, and may have very different symptoms and very different progression. But one of the common features amongst all of these disorders is that they are neurodegenerative disorders. And that's important to think about when we're thinking about how to design a trial. So I mentioned that leukodystrophies are rare diseases. So the definition of a rare disease by the Orphan Drug Act is a disease that affects less than 200,000 people in the United States, which for many of us and the specific disorders that we're thinking about seems like a crazily high number. So we're really often thinking not just in the rare space, but in the ultra rare space, where many times we're thinking about how to design a trial for something that has dozens of patients that we know about. I also want to point out that rare diseases are not rare. So there are over 7,000 rare diseases that we know of, and they affect more than 30 million people in the United States. So that's approximately 1 in 10 people have been diagnosed with a rare disease. So overall, although you have small numbers in each group, rare disease is very common. So like I said, I'm going to put some of my talk in the context of Canavan disease because that's one of my primary focuses, but I really want to think about generalizing this beyond one particular disorder into how to think more broadly about trial design. So Canavan disease, as many of you may know, and is a leukodystrophy with onset typically in early infancy. It's caused by a mutation in the ASPA gene, which is the aspartoacylase gene, which is responsible for breaking down NAA into its components of acetate and aspartate. So when ASPA is absent and non-functioning, NAA can't be broken down and it accumulates in the brain, in the spinal fluid, and can be measured in the urine. So clinically, these symptoms onset in the first months of life and are seen as increasing head size. So the children become quite macrocephalic. They have motor issues, which is normally first noticed as poor head control and hypotonia, never developing head control as expected, not reaching for objects as expected. And most of these patients do not develop the ability to sit up on their own. Visual issues are common as well, and nystagmus is another very common early presenting sign. And later in the disease course, a number of these children develop epilepsy. And so I've included on the right just a comparison of a 2-month typical MRI on the right compared to Canavan disease MRI on the left. And you can see the much more widespread involvement of these T2 hyperintensities here that are abnormal. And at the bottom, you see spectroscopy data, which shows a very elevated NAA peak. So NAA can be measured on spectroscopy as well. So before I get into ultra rare disease, I just briefly looked up the FDA drug approval process for typical, how does the FDA do their work? And this, since I mentioned I'm new to leukodystrophy since 2021, this was all new to me too. As a resident, you don't get exposed to much of this. So this was all good learning for me. So, what I want to highlight here is that this is what the FDA publishes on their website as their drug approval process. And I just want to highlight these numbers, right? So you see phase 1 studies, 20 to 80 people, hundreds of people in phase 2, thousands in phase 3. These numbers that just aren't applicable to most of the disorders we're looking at and are just very different from our reality. And oops. And this was really highlighted for me when I first started interacting with people who design clinical trials outside of rare disease. And I was proposing some ideas and they said, what do you mean you're going to have 10, 15 patients? That is crazy. So it's just an entirely different world. Okay. So a number of challenges, and really there's no way I could discuss all of them in this short period of time. So I'm going to be a little bit brief, but I want to bring your attention to challenges inherent to the disorder itself. So the clinical characteristics of the patient population, the symptoms and the disease, logistical issues, such as the potential duration of studies and the costs associated with them, issues of diagnosis and the timing of diagnosis, which I think we've focused on a lot with our discussions around newborn screening, and also briefly touch upon the ethics of clinical trials in this population. So clinical characteristics. I mentioned that these disorders are rare. We're finding one person out of this large group, right? So it's hard to identify and to diagnose, in part because of lack of familiarity in many of the, outside of our centers, and in part because we're looking for people all over the world who may not have access to the same level of diagnostics that we have in many of our centers. And then once we've identified those patients, we have to compete with this heterogeneity. And so again, I think this has been really well highlighted over the past 2 days, that although we may call something one particular disorder, that doesn't mean that each person looks the same, right? So while I say Canavan disease, and I think most of us who are familiar with Canavan disease think of it as something relatively homogeneous. You have this very early onset of severe symptoms, this quick decline, and pretty profound impairment. There is still enough heterogeneity that you have patients with milder courses, less severe symptoms, and atypical presentations. And when you're dealing with that, it becomes much harder to design a trial. Okay. So I pulled up this data from Dr. Bly's Canavan natural history study. And I just wanted to draw your attention to these different clinical characteristics. So I had mentioned earlier that the majority in Canavan disease are not able to sit up on their own, and you can see that represented here. But more than that, there is a lot of variability. So out of this cohort of 23 patients, 3 of them were able to walk with support, but still walking. And they did so at relatively typical ages. So 15 to 19 months as the age of gain of that milestone, slightly delayed, but still more or less within the normal range. And I also want to point out the ages of regression, right? So even those who gained those milestones tended to lose them. And when they lost them, it could take a while. So despite being able to walk around 1.5 years, it may be 3 years or 10 years before those skills are lost. So these are really slow clinical changes in many of these cases that we need to be thinking about. So this graph is not of Canavan disease. It's from another disorder that I study, which is UBTF-related neurodegeneration, but I think it illustrates an important point. So you're looking at the overall trajectory of disease. In UBTF, the patients have fairly normal early development with maybe a little bit of delay before plateauing and then ultimately regressing around the time late in the first decade of life. During the plateau period, there can be episodes of regression, oftentimes after illnesses, after sedation, and many times they then stabilize and sometimes regain back to or close to what their prior function was. And I show this because it's important to think about what your time scale looks like and what you're measuring, right? So if you want to look at motor outcomes, you have to know where you are in this curve. And in order to understand where you are in the curve, you have to understand the disorder, right? So you may say, oh, I looked at kids in this early phase and they all were gaining milestones after we treated them, but they probably would have anyway. You may look in this plateau period and say, nothing happened. Well, did nothing happen? Is that good because you've helped something, or were they just in this plateau phase? It's important to really think about where you are here. Another issue that, again, we've talked about and that really plagues the field is this conundrum of late diagnoses. So most of our patients in many of these disorders, not all, are being diagnosed because they're symptomatic, because they have symptoms, because they have developmental delays, they've gone to a neurologist for some reason, and we've sent testing. We know, especially for many of these infantile onset disorders, by the time they have symptoms, by the time we're seeing them, they're actually quite advanced. So we're catching them fairly late in this disease course. And so these kids who have advanced disease by the time they're being diagnosed have a lower baseline level of function. And if we enroll them in trials, we're less likely to see clinical improvement. Stability, perhaps, but when you have a certain amount of damage to the central nervous system, your expectations for the level of gain you can get are very tempered. And so unfortunately, once you're doing trials in patients who are more advanced, you may see less improvement, which leads you to be less likely to get approved, which then again makes it harder to do newborn screening so you can pick patients up earlier. And it's really this conundrum that you need to break out of in order to identify patients earlier for enrollment. I mentioned cost here. Cost is not really my area as a clinician and an academic, but I think it's important to think about all of the different factors that go into these trials, because you're really talking about very small populations when you're talking about rare disease. And so it's a lot of different things that need to come together and need to be funded. And while you're developing it for one particular disorder, it's important to think, how can I translate some of this work from one study to another to make things more cost effective and more able to proceed? And I also wanted to touch upon the ethics. So ethics could be an entire talk in and of itself, which I certainly don't have time for. But there are so many issues that come up when you're thinking about both designing and enrolling in a trial. So risk versus benefit is going to be a question with any treatment, with any trial, any patient that you're seeing. But in these particular disorders that we're treating, the risk-benefit ratio can look different than it looks in many other disorders. And I think it can be sometimes difficult for regulatory agencies or others who aren't familiar with these disorders to understand what that means. And for this reason, it's important to get families involved, to get those who know the disorders involved, and to say, this is actually what our priorities are. Other issues with the ethics include access. So we're often running trials, maybe in the United States, maybe in Europe. How do we expand access to get other patients involved when we know many of these disorders are present throughout the world? Dose escalation. So I work primarily in gene therapy, and Many of our gene therapy trials, we currently are only able to dose once. So we balance safety versus efficacy when we're thinking about selecting a dose. You want to start somewhere safe, but you want to be high enough to potentially give benefit. And so what we know is that there is a lot of unmet need in the community and an urgent call to action, and a need to move forward. So what are we going to do about it? And I think, everyone else who has spoken on trials and newborn screening has demonstrated most of the things that I'm about to say. But really the important thing is forming teams to learn from each other and also to learn from other programs that have had success, how we can translate that into our particular programs. So first of all, engagement of patients and families. And I think it was pointed out the importance to the FDA of patient outcomes, patient-reported outcomes. What matters to patients and families? What do they feel is impacting their quality of life? What do they feel is making a difference? Involvement of rare disease experts, which I'm speaking to the group, I suppose. Getting in touch with not just biostatisticians, which is important for any trial, but biostatisticians who understand rare disease and understand how to format things so that you're getting the most out of the sample size that you have. And of course, getting regulatory input early on. So back to this slide I showed you earlier. Once you have an understanding of the natural history, you really have a lot of power and a lot of ability to tailor what you're looking for. So once you understand the natural history, you can say, well, I know that I want to enroll at this age when I'm looking for this outcome. It helps you define the associated symptoms, and it also helps you select controls. Remembering that we're looking at these rare disorders, there are only so many patients, and most of them are going to want to be treated, right? So placebo control is not always as possible in these disorders. So you want to be able to say, I know what the untreated course looks like. And it's important to have this strong understanding of disease trajectory. So developing clinical endpoints, we've talked again earlier about the different types of things that regulatory agencies will be looking at as potential outcomes that they will accept. And one of the main problems is that most of these disorders do not have disease-specific validated outcome measures. So I'm showing here just an example of the Canavan Disease rating score, a result of the earlier Canavan natural history study, looking at some common domains within Canavan disease. But really, it's very difficult to develop these, and more difficult, as previously stated, to validate them and get them accepted. Quality of life measures, patient family interviews are also incredibly important, and I think looked upon positively by FDA. Biomarkers, so the kind of gold standard is if you can get a biomarker that shows correlation with clinical progression over the course of your disorder, which unfortunately can be very difficult in some cases to find. So in the case of Canavan disease, we have NAA, which we know is elevated in Canavan, and suspect that it is related to disease severity. But the full data on that is a little bit limited. We have some suggestions. So that still requires more work. There's also the thought of neuroimaging. Can we use some of these imaging findings to be able to determine if disease is progressing, and is that correlated with symptoms? And in many of these ultra-rare disorders, it may be, but we don't have enough published data to know really what the natural history of the neuroimaging looks like. And finally, wearable technology, which is becoming, I think, increasingly popular, trying to get some objective data of some of these motor impairments, particularly in movement disorders. So again, this goes back to some data from the UBTF cohort that I mentioned earlier, showing some correlation between movement characteristics, so it's an ataxic disorder, and a clinical rating scale of ataxia. So these are technologies that show promise, but still require a lot of validation in each particular disorder. And neuroimaging I mentioned. So in the case of Canavan disease, when I first started learning about Canavan, I think I learned what many people learn, which is that there's this widespread injury to the myelin in the white matter. You have these T2 hyperintensities that are fairly diffuse. And you also get this very swollen and macrocephalic appearance. What I learned after going through many, many images was that it actually seems like this is a particular progression over time. So in Canavan disease, from what I can tell from the early data, we have this early pattern of T2 hyperintensities that then evolves into a phase of swelling and ultimately devolves into atrophy later in the disease course. And it seems like there may be a spatial progression along with that temporal progression. This work is still ongoing, but it's important to think about, because if you have an idea of these stages and when patients are going through these stages, you have a better idea of when you can treat, right? So I think we all intuitively feel that if we're treating patients who have a large degree of atrophy, that's probably too late. So if we can define when patients are going into that particular stage, we have a better idea of what our cutoff should be and what our trial inclusion should look like. Newborn screening has been covered extensively, so I won't go too much into it, only to say that the goal of newborn screening is to cut out this difficulty obtaining early diagnosis. So if we can pick patients up early, we can diagnose them early, we can treat early, and we expect to have better outcomes in those cases. So lots of questions, maybe more questions than answers really, but I think there's a lot of good news here for the ultra rare disorders. And it's that many of these concepts are broadly applicable. I talk about a couple disorders, but really they can be applied much more broadly. And I think this has really been illustrated by some of the conversations we're having with the similarities between ALD, between Krabbe and MLD, right? There are so many similar themes. And so in the end, there's really no need to fully reinvent the wheel each time, even though there are differences, as this group is clearly learning from each other and teaching me probably as much as anyone. But I think, you know, as a team and as a group, there's a lot of room to move forward. And that is all I have. I want to say thank you to my group at MGH. Thank you to Dr. Eichler for being my mentor, and thank you for Katie for being my my pump up person, and also my other mentor. All right, thank you.